Many thanks for joining this Nova Signal educational webinar. We will start the event in 1 minute. Welcome to the first in a series of Nova Signal educational webinars. This one's entitled Embolus Detection with TCD, How and When to Use It. My name's Brenda Steffens and I'm the European Commercial Director at Nova Signal, and it will be my pleasure to moderate today's session. If you have any questions during the presentation, please type them in the Q&A field at the bottom of your screens, and time permitting, we will address these at the end of the talk. It's an absolute pleasure and honour to introduce today's speaker, Professor Werner Mess, Professor of Clinical Neurophysiology at the University of Maastricht in the Netherlands. Professor Mess has been involved in ultrasound since the beginning of his scientific career, generating a thesis on continuous wave Doppler measurements of the carotid and vertebral arteries in patients with asymptomatic vascular disease. Since then, he's performed and participated in multiple studies on plaque morphology as well as embolus detection. The latter led to his PhD degree on the physical properties of embolus detection in 2003. Currently, he's involved in the combined evaluation of functional and anatomical properties of the carotid artery by means of ultrasound, as well as studies on the role of TCD in the acute stroke setting. Professor Mess is an internationally recognized expert in this field and a member of the European Society of Neurosonology and Cerebral Hemodynamics and board member of the Neurosonology Research Group. Professor Mess, may I invite you to begin your presentation?
Yeah, hello. Is everybody seeing and hearing me? Okay.
Yep, you look great.
Okay, so welcome and well, thanks for attending this webinar. Let's start right away. Okay, so well, thanks again for attending, and of course, thanks to Nova Signal for giving me the opportunity to share with you my thoughts and ideas about this topic. And let's see, the host is asked you. Okay. Okay, so here is an overview of the talk. First, I will discuss very briefly the basic concept of microembolic signal detection. So what is it? How does it work? And then we go to 3 different fields of applications. And the first cluster is stroke, including symptomatic versus asymptomatic large vessel disease. And then guiding therapy, non-invasive and invasive. And the latter also comprises a discussion on particulate versus gaseous emboli. So what is embolus detection? We have here on the left side a transducer. We are now at the base of the skull, circle of Willis, and at approximately 5 to 6 centimeters, we encounter the circle of Willis in the middle cerebral artery, and we can record a signal from that vessel. So what happens here schematically? We have the transducer here. The ultrasound pulses leave the transducer and meet here the erythrocytes, which are flowing in this vessel. The vessel is going from here to there. So I will enlarge this. And here you have the ultrasound waves once again, huge waves, 0.7 millimeter is the wavelength. And they meet the erythrocytes, only 7 micrometer large. And of course, there is no reflection, but there is a backscatter. The ultrasound goes into all directions. This is the small gray arrows. But fortunately, a portion of this backscattered ultrasound is going back towards the transducer, and this is actually the basis of TCD. So I will give you an example how it sounds. Well, actually, I assume that this is pretty familiar to you, but now, of course, we get a next signal and it looks a little bit different and it sounds different. So listen very carefully. I do it once again because this is what it's all about. Okay, so I think you heard this blip or chirp in the middle of the signal, and that corresponds to this red dot over here. And this is a microembolic signal, or some people also call it a hit high intensity transient signal. So you saw this before. So what happens? All of a sudden, there is a relatively large particle within the bloodstream or in the sample volume. And then, of course, the intensity of the backscatter towards the probe will increase for a short moment. And that actually gives rise to this typical signal. This is a typical situation where we record the TCD signal and listen for microembolic signal. This is carotid. A patient is prepared here for carotid endarterectomy. We have the transducer over here and it is fixed with this kind of headband. Well, this is during surgery, but also in ambulatory patients. Usually a microembolic signal detection lasts for approximately an hour. And you cannot hold the transducer by hand, so you have to have this kind of fixation system over here. You saw this signal before, but I want to show you another one. And this explains, or this shows what the basic idea behind microembolic signal detection is, especially when it comes to plaques in the carotid artery. Well, this signal has been recorded just before cross-clamping the carotid artery. So the neck is opened. You can really see the internal carotid artery, and the surgeon then, he has a small rope and he lifts up the vessel a little bit. And that occurs here. The bloodstream is blocked. Obviously, the intracranial collateralization is very bad, so we have hardly any flow in the ipsilateral middle cerebral artery anymore. And one heartbeat later, we have the embolus. So before I go on talking, let's listen to this. Okay, once again. So what you hear first is the dip here, and then 1 second later, the embolus. And the interesting thing here is when you look at the velocity of the embolus, which is something like 40 centimeters per second, and you take the time into account and you know the distance from the internal carotid artery to the middle cerebral artery, which is approximately 30 centimeters, then you can easily see that this embolus has been dislodged by touching the plaque here indirectly. So this embolus emerges from the plaque that has been irritated, and an embolus in itself does normally not cause any symptoms, but it is an indicator that, in this case, a carotid plaque has the potential to shed emboli, and that is a very important risk marker. So I just said normally there are no symptoms, but of course you can have new lesions on imaging. These images look very bad and they are already very old. So this is the reason why. But still, these are images after carotid endarterectomy, and you can see there are new lesions here. Okay, so the same concept has been proven by a more recent study. This is a study in patients with intracranial pathology, and these authors found a clear-cut relationship between the amount of emboli and the amount of new lesions on post-procedural MRI. Okay, so that was the basis. And now let's go to the application. So as I said, I want to talk about 3 different fields of application, but of course there is a kind of overlap. There is no strict border between them. Let's start with the first one, and that was stroke or large vessel disease. This is from a very nice review, and it shows that you will have more emboli in symptomatic patients than in asymptomatic patients. And you will have more emboli in a stenosis with a higher degree of stenosis than in a low degree of stenosis. And this is also very important. The sooner you do the measurement, you perform the measurement, the higher the probability that you will find emboli. So this is immediately after the event. You will find a lot of emboli, and there is a gradual decay, usually within days. And you might say, well, these data are pretty old. Well, there's a study only 2-3 years old with a rather small. The group of patients was rather small, I think 40 or 50, and they observed exactly the same thing. So microembolic signals were commonly observed when you were quick with your examination, and especially in symptomatic patients. But when you were somewhat later, so let's say a week later or so, the percentage of emboli positive patients was much lower, and that was the same actually as in asymptomatic patients. There are two things or two characteristics that are very important for performing the measurement and for sensitivity and specificity. The first thing is, unfortunately, there is quite a variation in the occurrence of microembolic signals. These are data from 12 patients. The recording lasted 5 hours. And here you can, for example, see, well, let's see, for example, patient 4. You see that there are a lot of emboli in the first hour, well, considerably less here, but the 5th hour is completely negative. So I said before, usually a monitoring session would last for 1 hour. So if you would do the monitoring session here, that would be a false negative result. So that is a little bit a problem. Another point is, and that is very interesting, a study recently published from the group in Australia. What they found was that there is even a variation in the course of the day. So the consequence of these data is, this is data from asymptomatic patients, you better get up early in the morning and do your embolus detection. And this, of course, fits very nicely with the concept of wake-up strokes, and that these wake-up strokes occur very often. I think this is, meanwhile, a pretty, a well-known slide, and still the best one and the best study we have. This is on patients with symptomatic carotid artery stenosis. 2 times approximately 100 patients. 100 patients had emboli at the beginning when they were recruited. 100 did not. All patients had a carotid stenosis of at least 50%. And the result, after a follow-up for 3 months, I think is pretty clear. Here on top, we have emboli negative patients, here the emboli positive patients. So no new event occurred in the embolus negative group. And of course, new events, approximately 15% in the emboli positive group. Actually, there has been another study that has been performed earlier, and they found more or less the same. So no new events in the embolus negative group. And they actually did repeated measurements, so this is why we have here persisting. But in fact, or essentially, it is the same. This is a very recent study, and this is on a different patient group. This is on patients who have undergone intra-arterial thrombolysis. And the authors performed a microembolic signal detection on the day after the procedure. And what they found is that there was no relationship between the actual outcome at that moment, but what they found was that there was a huge, there was a high predictive value for the occurrence of a new event, again, within 3 months. The interesting thing here is, so this does seem to work not only with large artery occlusion or stenosis, but this is a mixed population. This is a comparable study. This is just, again, natural cause, a mixed group of pathologies. So again, the clear-cut differentiation between emboli negative and emboli positive patients and the development of a new symptomatology. Interestingly, and fitting with the concept that you don't actually need a carotid artery stenosis, is this nice recent overview showing that especially in embolic stroke of unknown origin, the proportion of emboli positive patients is pretty high. So this is a, I think, very valuable indicator. So this sounds all pretty good, I think. And so let's see what these people have written in their review on the topic. Well, indeed, if you have emboli, then the chance is pretty high of getting a new event. And if you don't have emboli, the chance is pretty low. So this seems to be clinically useful, but there is a tiny problem. The authors find the studies not strong enough, and they don't dare to give final recommendations. So this is a little bit of a problem we encounter regularly in embolus detection, that the quality of the studies or the scale of the studies doesn't fulfill strict criteria for definite recommendations. But the fact that we do not have evidence-based recommendations here doesn't mean that it makes no sense or that you shouldn't do it. In my opinion, it means that you have to think yourself. So are the data, for example, the ones I just showed you, enough for you to, at least in difficult patients, to adjust your therapy on the basis of microembolus detection? I think it's definitely worthwhile to think about it. So we switch now from the symptomatic to the asymptomatic carotid artery stenosis. And that is actually my favorite, I have to admit. This is one of the two large studies. Almost 500 patients have been followed up here. And again, you can clearly see that the emboli positive patients have a worse prognosis when compared to the emboli negative patients. This is the other study. This is from Canada. And it's the same story, emboli negative, emboli positive. But there is an important thing here. What we see is that after 2003, there were much less patients emboli positive. But still, there was even if the authors analyzed only this group, there was a clear-cut relationship with future symptomatology. So this is in this review, and you saw a figure of this review before. Everything is taken together. Meanwhile, we have data from more than 2,000 asymptomatic carotid stenosis patients, and there is a huge difference when it comes to future symptomatology. The emboli positive have a much higher risk than the emboli negative ones. And you can go even a step further, because what you could do is to combine the information of the emboli with information on plug properties. So also acquired with ultrasound. So what we see here, the green line, these are patients who were, again, asymptomatic patients who had emboli and who had a very echolucent plaque, so predominantly consisting of lipids and blood. And you can see that the difference in terms of risk of a future event is even larger. And I think this is very important for the practical implementation. So the red horizontal line indicates the assumed risk you undergo when you have carotid endarterectomy. So this is roughly the risk of a stroke or TIA when you are operated on. And you can clearly see if you have no emboli and your plaque is not black at the same time, you are very well below that line. So it might not be a good idea to undergo surgery. On the other hand, if you belong to this group, you should have a clear-cut advantage when you get operated on. These are guidelines from the European Society for how to treat symptomatic and asymptomatic carotid artery stenosis. And this is a very important table, but don't read it or don't try to read it. This is just to illustrate what they did. So we have here in the first column all the different methods, and in the last column we have the predictive value, mostly expressed as the odds ratio. But again, don't try to read it. We will come back to this in a minute. The asymptomatic carotid artery stenosis draws a lot of attention these days, and this is one of the typical review papers, or actually opinion papers, how we can do this. And interestingly, these authors, they put forward a strong argument for advanced imaging like MR or CTA in order to evaluate which asymptomatic carotid artery stenosis should be operated on and which not. And interestingly, you find this in the paper. So the intraplaque hemorrhage, which is usually a very good marker, wasn't even significantly different between those who became symptoms and those who didn't. Well, this is a little bit political stuff, but I think you can draw your conclusions on your own. Well, I promised you that I would come back to the paper I mentioned before, and I have changed the table. So what I did is I sorted the different ancillary methods according to their odds ratio. So the higher the figure, of course, the better the predictive value. And I left this open and give you a moment to think about it. So which methods, anything, MRI, CT, ultrasound, TCD, MES monitoring, autoregulation, what is the best method to predict whether a person with asymptomatic carotid artery stenosis will get symptomatic? Well, this talk is on microembolic signal detection, and I think you might expect what you are going to see now. Indeed, it is the microembolic signals and the combination with the echolucent plaque that gives definitely the best odds ratio. Then only the microembolic signals, another TCD parameter. Here we have the MRI, CT, and so on. So actually, the microembolic signals are the best parameter to identify which asymptomatic carotid artery stenosis patient will get symptomatic. Well, I think this is very important because this is a very recent statement published in the JAMA and on the question, should we screen for carotid artery stenosis? So to find all these asymptomatic carotid artery stenosis, and the answer is simple, no, don't do it. And the main argument is not the cost of screening. The main argument is that these people are afraid that those patients who have an asymptomatic carotid artery stenosis will undergo harmful, for example, surgical procedures. And you just saw the slide with the horizontal red line indicating that this is a real scenario. So here you can see a comparison how different countries treat asymptomatic carotid artery stenosis. So some countries, they like to operate on asymptomatic stenosis. Others, they don't like it at all. And actually the Netherlands belongs to this group. But I think it makes not so much sense to operate just everybody or nobody, but to have a more differentiated view on this topic and perform, for example, microembulus detection. Because only 3 to 4% will have microembolic signal. And as you could see from the slides, only these patients are at a real risk. We now switch to a next topic, and that is guiding therapy non-invasive. This is a typical example of a large-scale study on the effectiveness of medication. So, large scale, indeed, almost 20,000 patients. You can already see that the result is a disaster, so no difference at all. But maybe the biggest disaster is that we have more than 2,000 events, so strokes or TIAs. Well, you could say, well, we should treat the patients more aggressive. Well, this is another trial, and well, one of the arms indeed was more aggressive. 3,000 patients, but again, no difference in the two treatment arms, but things get worse, a lot of side effects, and fortunately, the trial was stopped early. So again, 3,000 patients, which did only harm to the patients. So the question is, couldn't we do this smarter? And this is an example from a different angle of view. This is from a group of Ireland. They are very active in this field, platelet function testing. And in this paper, they proposed this idea. So as you just could see, the majority of patients actually are not protected by standard therapy. And the idea is you measure, in this case, the inhibition of platelet function by medication, and then you can tailor the therapy of an individual patient. So maybe somebody needs a higher dosage or a different medicament. Well, you just could measure the effect of the medication. So the question is, isn't that something that we also could do with microembolic signal detection? Yes, we can do that. And we know that since quite a long time. This is a study of only 9 patients, but it was published in Stroke. So these are all patients who were emboli positive when they arrived in the hospital with a stroke. And you can see here the amount of emboli could be quite a lot. Then intravenously aspirin was administered, and there were several repeat measurements. Now what you can see is this is the sum of the first 7 patients. You can see that there was a clear-cut reduction of the number of microembolic signals. So in other words, the aspirin worked. But the most interesting thing are patients number 8 and 9. You can see that nothing is happening, not on the short term, not on the long term. So these patients, 2 out of 9, they are really non-responders. And without embolus detection, you just wouldn't know. The COREST trial was also 100 patients, showed also that you can measure the effect of medication. In this case, people were randomized and everybody got aspirin, but half of the patient had placebo and the other one had additional clopidogrel. And you can see what happened. So we have microembolic signal measurement at day 7, so 1 week later, dual therapy, so the combination monotherapy. And what we can see is indeed the addition of clopidogrel leads to a lower count of microembolic signals after a week. And they also looked at the outcome. And unfortunately, the study was somewhat underpowered for that, but still we can see that the combined outcome for TIA and stroke was considerably better for the dual therapy than for the monotherapy. So taken together, so you can measure the effect of medication, and you can also show that changing medication changes clinical outcome. This is another slide on the relationship between microembolic signals and platelet function. This is approximately 40 patients. Most of them got aspirin, loading dose, and the usual dosage afterwards. Some of them got clopidogrel, and all patients got the same dosage, and according to the usual regimen. And then the platelet function was evaluated, and you can see that you had either sufficient aggregation or insufficient aggregation, and that correlated very well with the occurrence of microembolic signal. So if you had insufficient aggregation, the likelihood of having microembolic signals was very, very high. So again, this is an indicator that you can use your microembolic signal detection for measuring whether or not your antiplatelet medication is working or not. And think about it. I mean, think about a patient with hypertension. I mean, if somebody comes in and you give medication, you wouldn't say, okay, goodbye and good luck. But you would say, well, either buy an instrument to measure the blood pressure daily at home, or at least ask, come in regularly. You are going to check for this, for the blood pressure and whether the medication is working or not. This is not what we are doing with atherosclerosis. And here we have a very nice situation where we could do it. This is on statins. It is known that if people are on statins for whatever reasons and they get a stroke, the stroke is usually milder than when compared without statins. And here embolus detection has been done, and indeed, if the people had statins before the event, there were much less emboli, and if the statin dose was pretty high, then the effect was even more outspoken. So again, another indication that microembolic signal detection evaluates the function of medication. Well, slowly but surely we move to the invasive therapy, but not yet. So this is after carotid surgery. This lady here is monitored, and I will now start this audio file here. It's not easy. I'm not sure whether you heard your embolus in the middle. It's very high frequency, pretty tiny. Okay, so we are recording here emboli after carotid surgery. So this is how we did it. We had a machine recording. This is not built or sold anymore. Patient was connected to the machine network. Technician is sitting at the department and is remotely checking the emboli count, which is analyzed automatically. There is no time to discuss the automatic detection of emboli, but this, of course, is a very important aspect here. Well, what is the basis for doing this? Well, that is mainly this publication. This was the first publication in Brain. And what they found in these roughly 60 patients was that all the patients with the red arrow, they had a stroke or TIA post-operatively, and all of them had more than 50 emboli per hour. So this is why we do it. Well, this worked pretty well. And then people, I think in Leicester, they started to administer clopidogrel before carotid surgery. And what then happened was that the incidence of patients who had more than 50 emboli per hour decreased considerably. So from 14 to 3.7% in this study. They even argue that it makes no sense anymore to do post-operative microembolus detection. So we were a little bit suspicious about this. So we analyzed our own data from the last 1,000 monitoring procedures. We do this in 2 centers. Each center, luckily enough, had almost the same amount of patients, so we could compare that nicely. And emboli positive means more than 50 emboli per hour. So what we found is that there was a difference between the 2 hospitals, and we tried to figure out what the reason was, and we just, we don't know. We then looked for changes in time. So in this hospital, there was no Plavix, no clopidogrel during this area. But then in 2011, the surgeons, they administered preoperative clopidogrel due to the study from Leicester. And you can see that indeed the incidence of emboli positive patients halved. The other hospital, they didn't do anything, and they just stayed pretty low. So I think these data, they show us that indeed the preoperative clopidogrel works. So we have less microembolic signal positive patients postoperatively. But it also shows us that it's not that easy to compare the results from one hospital with the other or to the other. So I think this means you should gain your own experience and try it by yourself, how it works. But I think it is useful to do this postoperative monitoring, because what we do now is if there are too many emboli, and of course we do not wait a full hour before we have 50 or 100 or whatever, but if we see that it all goes into the wrong way, so this is microemboli per 10 minutes, and here we have 12 and 16, so this, if you extrapolate, you will end up with much more than 50. So then we administer 500 milligrams of intravenous aspirin. We take a break because it takes a while that the thrombocytes react on this, and then we see that the count is much lower, and then everything is fine. So you could wonder, why is it possible? Because the patients usually have preoperatively aspirin. So if we administer again aspirin, why does it work? Well, this is a paper using an animal model, actually a rabbit model with, and what they found was for aspirin and for clopidogrel, a clear-cut dose relationship. So the higher the dose, the lower the frequency of microembolic signal. So this is the reason why this very high dose of 500 milligram aspirin, and we repeat this once if necessary, is helping. Now this brings me to the last topic, the last application cluster or field, and that is monitoring or adjusting therapy when it comes to invasive therapy. These are carotid artery stents, and the one above is a relatively new type. It's called road saver. Oh, okay. And the authors checked whether using the new type would result in less emboli. And of course, the idea is that the emboli serve as a surrogate marker, and the fewer emboli you produce, the better for the patient. And you see indeed that the road saver is a little bit better than the other one, but the huge difference between these two ones and these two ones is actually caused by a thing that is called MoMA, and this of course is not the museum in New York, but this is a protection device that is in the distal internal carotid artery. But embolus detection as a surrogate marker is by no means exclusively used by carotid stenting or whatever, but also, for example, by left ventricular assist device in left LVAD patients. So this is a study on more than 500 patients, and they encountered in 41 patients strokes or TIAs, and in a considerable portion of these patients, they were able to measure microembolic signals. And it is indeed a pity that there is no control group in this paper, so we don't know if in the group without TIA or stroke, if there were emboli or not. So in other words, how good do these emboli discriminate? But the authors mentioned different complications of LVAD, and that the microembolic signals were correlated with that. This is, these are new lesions on neuroimaging. And how were these lesions caused? Well, this is from a study where a new catheter for atrial fibrillation treatment was tested. And it has a very promising name, the gold catheter. Well, okay. But unfortunately, the lesions you just saw, they occurred much more often with this new catheter. So the older type was much better. And that correlated very nicely with the emboli they were able to measure during the procedure. So I said it in the beginning, the idea is that microemboli themselves do not cause symptoms. So if there is a single microembolus going upwards, you will not have a TIA or something. But it is an indicator that there are processes going on that might cause more or larger emboli to get released, and then you really have symptoms. So that is the idea here. And this, of course, is one of the most famous applications for microemboli measurements. This is cardiac surgery. In this case, this is valve replacement. And every dot here is an embolus. And the larger the dot, the more emboli are here. So you can encounter thousands of emboli during such a procedure. I will come back to this slide later on, but I already want to mention that this box here is very important. So I will give you an example how this sounds or how this may sound. So actually, these are quite intense microemboli, and you see that they distort the signal, and this, of course, is completely unrealistic that they are at the same time below the zero line. So the dynamic range of the TCD system is not sufficient anymore to capture these signals. And here we have another 3 examples from one of our studies. Excuse me. So they can occur rarely, more often, or sometimes regularly. This can be so extreme that you only see white emboli, which would be called a curtain. So I wanted to go back to the slide, and here it is again. So why am I showing you this again? These authors, they did pre- and post-operative MRI of the brain. And there were new lesions indeed, but these new lesions, they were only correlated to these emboli. And these emboli are particulate emboli, and they stem from the moment when the clamp of the aorta is released. And very often people will have plaques at the aortic arch. So if you release the clamp, particulate emboli will go into the brain, and that will cause new lesions. So this brings us to the discussion on particulate and gaseous emboli. We see, especially on the lower figures shows this very clearly. This is a measure, let's say, for the intensity of an embolus. So if you have a low intensity, the chance is pretty high that it is a particulate embolus. If the size is larger, you can assume that it is a gaseous emboli. And this is simply due to the fact that the gaseous emboli, they are not larger, but air scatters back much more ultrasound than particulate material. So take it together. If you have a very large embolus, you can almost be sure that this is a gaseous emboli. If you have a tiny one, a small one, you can be pretty sure that this is particulate. But there is a considerable overlap where we just cannot tell. But nevertheless, you can find now and then studies where both gas and solid emboli, so gaseous and particulate emboli, are reported. This is from a study where embolus detection has been performed during endovascular treatment of aortic aneurysm. This is the total procedure, and the interesting thing is all the different phases, all these stages of the procedure, you see that the ratio between gaseous and solid is exactly the same, which is a little bit counterintuitive because differential mechanisms or different stages should result in different kind of emboli. And here we have a comparable example of another study. This is again during treatment of atrial fibrillation, and they measured the activated clotting time, and you see here the gaseous ones and the solid ones, and their relation with the activated clotted time. And of course, the higher the activated clotted time, the less embolus, the less emboli you have. And again, you see for the solid and the gaseous ones exactly the same behavior, which is also pretty counterintuitive because, well, they consist of definitely different material. So you might have some doubts about it. So how do these people, or why do these people think that they can discriminate between gaseous and particulate emboli so easily? Well, there is an attempt, and or the idea is to use two different frequencies at the same time, and that is 2 and 2.5 megahertz, and that should theoretically result in a different backscatter from particulate and from gaseous emboli. This is something to do with resonation of the gaseous emboli. In theory, this might work perfectly, but there are really some aspects that make you wonder whether it really works. And these very nice pictures, they stem from David Evans. And what you see here is the ultrasound field that is generated by a 2 and by a 2.5 megahertz transducer. This is just in vitro, and I would say, well, this is pretty much the same. But the problem starts when you use, or when you bring into this in vitro experiment a piece of skull, a real skull. Here you see the ultrasound field behind the skull when using a 2 megahertz transducer, and here we see the field when using the 2.5 megahertz transducer. Well, you might think, well, it's pretty much the same, it's okay, but here we see the difference of the field when you look at these two pictures and when you analyze what the differences are. And the difference are considerably. This goes up to 3, 4, or 5 dB. So the probability that you make an error concerning the correct classification between gaseous and particulate emboli, well, the probability is pretty high. So that is a pity, because it would be very important to be able to discriminate gaseous and particulate emboli consistently, not only under these circumstances, but I think there is still a lot of work to do before we are really able to do it. Well, this brings me actually to the wrap-up. These were the topics I addressed, and I choose different colors for, let's say, the importance or the readiness for implementation in practice. So my number one definitely is the asymptomatic large vessel disease. There are lots of studies. There is level A evidence that the detection of microembolic signals in patients with asymptomatic carotid artery stenosis indicates future risk. And I think this is really worthwhile to consider it. This is number two. So using microembolic signal detection in patients with stroke, having symptomatic large vessel disease or not, in both cases, it might be a good idea to do it, and also post-carotid endarterectomy. And this is the third group. I think the first topic, so the possible role in tailoring medication, that might be interesting for a lot of people. And so the second one, possible role in improving invasive techniques. This is only for a minority, I think, of our colleagues who are busy with developing new techniques. But this might be something of the future. And of course, we need more studies on this, that this has really a positive effect on the outcome of the patients. That brings me to my last slide. And yeah, I would like to thank you for your attention. I hope that this was interesting, that I was not going too fast, but there is room for questions. So I'm curious about that.
So many thanks for the excellent presentation. We have indeed received a lot of questions. And I would like to start with the first one, which actually came in prior to the talk. And that is, are there guidelines available recommending the use of emboli detection?
Yeah, that is a good question. I think this depends on the country where you're living. Actually, in the Netherlands, we don't have these guidelines. And as you can see from the paper from BEST, embolus detection in stroke patients and patients with asymptomatic and symptomatic carotid artery stenosis delivers clinically useful information. They still do not dare to give recommendations. And the argument is that the quality of the studies is not sufficient. So formally, the answer is no. There are no clear-cut guidelines, but this by no means means that it does not make any sense.
Great, thank you. I've got a question here from Mark Rubin, which says, thank you so much for this interesting talk. Given the difference in signal intensity between particulate and gaseous emboli, do you feel that the 1998 international consensus criteria sometimes fail to capture particulate emboli? In practice, I've noticed that emboli that should be particulate, so carotid tail emboli, that are intense, over 9 dB over background, transient and clearly moving in space and time, but do not chirp. Without the chirp, they per se do not meet the criteria, but the repeated signals arising from the same spot are highly suggestive of particulate microemboli.
Yeah, I couldn't agree more. And actually, there is a working group from the European Society of Neurosomnology and Cerebral Hemodynamics. And this working group is working on new criteria. And I already can tell you that the time domain signal will play a major role in these new criteria. Yeah.
Great.
And
so I've got it.
Excuse me, I can only confirm your observation. We indeed sometimes see microembolic signals where you have your doubts about the acoustic properties, but you then can clearly see the typical signature and the time domain, and yeah, then it is obvious.
Okay, great, thank you. We have a question here from Salkarami. It's a great talk, thanks Werner. Why can we go lower than 2 megahertz, for example, to 1.7 for emboli detection? That might help insulate those suboptimal windows. First part of the question.
Yeah. Okay, then, so yeah, okay, go on, yeah.
No, and then please tell me how much you decrease your gains during monitoring.
Okay, so the second question is definitely the easiest one. So switch off the envelope, because it will drive you crazy, because if you lower the gain, then of course the emboli will sink into the Doppler in the FET spectrum, and you don't need the envelope. You're not interested into the velocities. So I think I showed some examples. Usually I would go for blue and a little bit of green. So most machines work like that, so that you can just see the Doppler spectrum. Yeah. And of course, this is not only the gain, it's also the power. And of course, I use the lowest power possible. Of course, we do this all the time. But of course, it makes no sense to use a high power and then dampen the gain. So I would start with trying to use the lowest power that we need to get a good signal, and then adjust the gain. And the first question indeed is a good question. I also wondered about that, but I talked to several people, for example, Rooney Arslet, and he told me that it really wouldn't make so much sense in the end. And indeed, we have some experience with that, because we used some prototypes of him with 1.5 megahertz transducers, and I really can say that we had more bone windows than with our usual 2 megahertz system. So in practice, it doesn't seem to matter that much.
Thank you. I've got a follow-up question from Mark Rubin, who says, how do we best come together as an international community to bring TCD clinical research out of the doldrums of low-level evidence into something fit for clear guidelines?
Well, excellent question, of course. Well, I hope that this webinar might help reaching that goal, because what we definitely need is huge numbers. So when you looked at my slides, or when you look at the data and you see that we have data from more than 2,000 asymptomatic carotid artery stenosis patients, and all data point into the same direction. There is not a single study that couldn't confirm these findings, and still it is not in the guidelines. Then you really have to think about it. And I think only huge numbers will convince the people who make the guidelines. Yeah. And I think also what is also important, I mean, the ACES study and the Canadian study, they are already, meanwhile, 15 years old. Medication has changed. So what we really need is actual data right now and show that it is still worthwhile to do this. Yeah.
Okay, thank you. I have one possibly last question from Richard Genova. Hits and embolic strokes of undetermined source seems to be an especially important arena of research that needs TCD monitoring for emboli. Do you also see or know of any efforts to look at non-cardio, non-vasculature surgeries that might benefit from embolic monitoring, for example, orthopedic procedures such as knee replacement?
Yeah, this is a different field. It is known that you can, for example, in knee surgery, you can have fat embolism. It is also known that in acute myocardial infarction, you can have emboli. This is a little bit more, well, I'm not aware of so many studies on, let's say, other procedures. So the procedures you mentioned, for example, and then the importance of microemboli for example, cerebral complications. I think this will, this will bring us more into the field of research of embolization in general. Because what is very interesting is that, and this everybody finds it, if you are not lazy and you do your microembolic signal detection immediately when the patient arrives at the hospital, so with symptoms like TIA or stroke, you will find in a huge percentage microembolic signal. And when you repeat the measurement 1 day later or 2 days later, you will see that the percentage of positive patients will have decreased considerably, irrespective of medication. So there must be something going on a very short term. And the percentage of microembolic positive patients is so high, so something like 30 or 40%. These patients, they don't all have atrial fibrillation or carotid artery stenosis. So there must be a common denominator at that during the emergence of the stroke or the TIA. This is very fascinating, of course. Yeah.
Well, thank you very much. We've run out of time. May I thank you again, Professor Mess, for this excellent presentation, and also the participants for the interesting questions. I think this has been an excellent first session. Please look out for further announcements from Nova Signal about future educational events, and thank you very much for your time.
Well, thank you for listening.